Okay, Dr. Nunes, it's all up to you.
Great. Thank you, Joanne. Good evening, everyone. For those of you who don't know me, my name is Ken Nunes. I am in the section of General OBGYN, and I'm also currently the Senior Vice President and System CMO, Chief Medical Officer for Ambulatory. Tonight, though, I'm here to talk to you about the treatment and management of mental health conditions during pregnancy and postpartum, which is obviously a very important topic for us and also the patients that we see. So I'm going to jump right in. Um, Again, I've already mentioned who I am, and I have no relevant financial or non-financial conflicts of interest to disclose. So the objectives for this evening is several-fold. First, to recognize the prevalence and clinical impact of perinatal and mental health conditions, review and apply ACOG recommended treatment principles, including when to initiate, continue, or adjust medication therapy during pregnancy and postpartum. Three, how to counsel patients effectively on a risk-benefit trade-off for medication therapy. And the last objective is to identify obstetric red flags requiring urgent psychiatric intervention. The background is on the slide. I'm sure some of you may be multitasking and not looking at the screen, but we'll go over the background, ACOG recommendations, risk benefits of treatment, screening approaches, treatment, team-based care, and then some resources all of you can use if you're not already using. So just a question for the group, just to start it off. It's a Slido question, but um, during pregnancy and postpartum, uh, true or false, 1 in 5 patients will develop a mental health illness. And the answer is true. I was going to do a poll, but I'm sure many of you may not be on their computer at the moment. Second question, it is within the scope of practice for an OB provider to prescribe medication for the treatment of depression, anxiety, in pregnancy and postpartum. And the answer to that, and we'll go over it in a second, is also true. And finally, well, let's see, you won't be able to see that one, so we'll keep moving along. So a little bit of background. First of all, mental health issues affect women more than men. Almost 28% of women will have a mental illness compared to a little under 20% of men. And about 20% of women will develop a mental health condition during pregnancy or postpartum. So the first takeaway is this is common, and it's something that we will see frequently in our clinic when we're taking care of pregnant and postpartum patients. Um, Perinatal depression includes many symptoms, many of which you know, but persistent sadness or anhedonia, fatigue, sleep disturbances, feelings of guilt or inadequacy, and paired bonding or disengagement. And the one thing I want to point out on this slide is that the technical definition of depression includes the onset of depressive symptoms during pregnancy or up to 4 weeks postpartum. However, most experts, including ACOG, recommend extending this to 12 months postpartum. Again, it's very common. 20% of women, 1 in 5, can develop depression during pregnancy or postpartum. And perhaps even more surprisingly, or not, 1 in 4 women will have persistent symptoms for 3 years or more. So it's common and it can last. So anxiety, fair amount of overlap, and many people who have depression will also have anxiety, but the key symptoms that you clue us into a patient having potential anxiety is excessive worry or rumination, whether that's about the pregnancy or their baby, hypervigilance about infant health, restlessness and insomnia, and a lot of somatic symptoms, so palpitations, tension, etc. It too is frequent, occurs at about the same frequency, 1 in 5 women. And as I mentioned, it also frequently occurs alongside depression. It is associated with some adverse maternal and neonatal outcomes, including preterm birth, low birth weight, and behavioral changes in offspring. Bipolar, we're going to see less commonly. Oftentimes, at least in my practice, patients will come in with a history of bipolar. So diagnosing it is a little less common, but it is really important that we are acutely aware of potential symptoms which may indicate someone may be experiencing bipolar disorder. And these symptoms are episodic mood elevation or irritability, decreased need for sleep with increased energy, racing thoughts or pressured speech, risk-taking or impulsivity, and marked mood lability, particularly postpartum. As I mentioned, it is less common, but if there's anything that you remember from this discussion tonight, it's the following, and that is 23% of women who screen positive for depression have underlying bipolar disorder. And why is this the one of a few points that I really want you to remember? It's important because honestly, we're not very good about subsequently screening for bipolar disorder in someone who screens positive for depression. And the reason that it's important is because if you treat a patient who screens positive for depression and you treat them with an antidepressant, and the patient does have bipolar disorder, you could actually exacerbate their mania or their psychosis, which could result in self-harm or infanticide, so harming their child. So this again is something that we don't necessarily do well. It's something that we need to do better, and it's I think an important point to take away from the talk this evening. And we'll circle back and talk about it a little bit more. Um, for those of you who may be less familiar with the screening tool for bipolar disorder, it is called the Mood Disorder Questionnaire. It is embedded in Epic now, and it is important that we use this to screen patients who screen positive for depression. For the prescriber, for us as a nurse, if someone screens negative for on this screen, you can treat for you can treat for their depression with an antidepressant, so usually an SSRI. If they're positive, it's very important that we refer them to psychiatry. Postpartum psychosis, the rarest of things we will see. In 30 years of doing this, I've had one patient experience postpartum psychosis who was ultimately admitted to the hospital, but it occurs in about 1 to 2 per thousand pregnancies, and it can be very, very severe. The typical onset is usually within days after delivery. And as an OB or a nurse working with an obstetrician, we need to be prepared to get them the help that they need as soon as possible, usually at admission to the hospital, to psychiatry, getting psychiatry involved. And if there is a delay in that, we as obstetricians need to be prepared to treat them with antipsychotic medications, which is usually something like Haldol. Just to be aware of the symptoms, again, it's usually disorganized thinking or behavior, even delusions or hallucinations, loss of insight, and as noted, they could become a safety risk for themselves. And for those of you who are old enough to remember, this will appear in the news every once in a while of some horrendous story of a postpartum mother who became psychotic days after giving birth. Andrea Yates is probably the most notorious person that comes to my mind. That was well publicized. Several books were written about this case, but she is the one who filled her bathtub up with water and drowned each of her five, very tragically drowned each of her five children. And this whole case really brought into the spotlight, the issue of postpartum psychosis. So I'm going to run through some ACOG recommendations fairly quickly, and then we'll talk about some screening and treatment. But thankfully, ACOG is very clear about how we as caretakers of pregnant patients should approach mental health in pregnancy and postpartum. So, general approach, some general principles is that as OB providers, we need to be prepared to counsel patients on the risk and benefits of drug treatment. Um, we need to aggressively treat depression and anxiety and refer to psychotherapy as needed. We should be, and we are, thankfully, using validated screening tools, although I think we have some opportunity with using MDQ for bipolar disorder screening. And then we should really never withhold medication simply because someone is pregnant or breastfeeding. For first line therapy, we should always be considering psychotherapy. I know oftentimes it's difficult to get patients to commit or go to therapy. Um, and then in some cases, we do need to initiate drug therapy. And usually for depression and anxiety, those will be the selective serotonin reuptake inhibitors. As a general principle, though, if someone is already on a medication, it's not an SSRI, but it's working, we tend to keep them on it. Uh, and if they're completely new to drug therapy for depression or anxiety, then we will usually start with Zoloft or Lexapro. The treatment for anxiety disorders quite simply mirrors the same as they do for depression. So again, if they're open to therapy, we'll send them to therapy. If they're on a medication that's already working for them, great, we will continue them on that medication. If they are completely new to medication, then our first choices would be Zoloft or Lexapro. Benzodiazepines, so things like Ativan um, or Xanax should be avoided or prescribed very sparingly in pregnancy. And quite honestly, we would usually engage a psychiatrist if we were in that position. So, bipolar disorder, just as a general principle, we will co-manage pregnant patients who have bipolar disorder, usually, not usually, almost always, with a psychiatrist. But if a patient is on medication for their bipolar disorder before pregnancy, we should not discontinue it, with one exception, that is valproate, just because it is potentially teratogenic. And so if someone is on that and they are newly pregnant, we would need to switch them, and we would do that with the engagement of their psychiatrist. There has been some concerns about the use of medications for the treatment of bipolar and how they might affect um, uh, just or diabetes. And so there were some earlier recommendations about screening pregnant patients who were on medications for bipolar disorder earlier, but the current ACOG recommendations is to simply screen with a 1 hour glucose tolerance test at the usual time, so between 24 and 28 weeks. For those patients with bipolar disorder who are on lithium, it is recommended that they do receive a second trimester detailed anatomy scan and sometimes a fetal echocardiogram to screen for congenital heart defects, because there is some data that if exposed in the first trimester, there's an increased risk for Epstein's anomaly. That is always a board question for physicians, but just important to note that we will need to do a deeper look at the baby's heart if they are taking lithium. Postpartum psychoses, the things to remember about this. Rarely will we see this, number one, but if we suspect a patient is psychotic, we need to engage psychiatry immediately, and we need to get the patient hospitalized. If there's concerns about getting them to where they need to be, it is incumbent upon the obstetrician to begin some antipsychotic so that they don't hurt themselves or their baby. But the takeaway is that postpartum psychosis is almost always managed by psychiatry. Our job is to get them to the psychiatrist or to get them hospitalized as soon as possible. So let's talk about screening. I know this can be confusing, and if we haven't changed, we're about to change a bit how we approach our screening. Um, so the two most common ways of screening for depression in pregnancy is the Edinburgh Postpartum Depression scale, which is something that UCM has used for as long as I've been at UCM, since 2010. But you can also use the Patient Health Questionnaire, the PHQ-9. ACOG doesn't prefer one over the other. Um, Both are validated instruments for screening for depression. We internally have had some debate about transitioning to PHQ 9 for depression screening in pregnancy. Um, Primarily because throughout the entire organization, we are screening for depression now in all clinics annually. And that is being done with PHQ-2, which I know is also being done in our clinics for our gynecologic patients. It has created a lot of confusion. PHQ-9 is a validated tool for pregnancy, and actually, there is some data to suggest that PHQ-9 has a higher sensitivity and performs better than EPDS for our African American population. And I was going to confirm before this talk, but I know we are planning to transition to PHQ-9 for depression screening for our pregnant patients. So if that's not in place, that will be shortly. There'll be some communication about that. And I think it will make things far less confusing in that we will be screening all our patients with the patient health questionnaire, whether that's the PHQ-2 for screening non-pregnant patients or PHQ-9 for our pregnant patients. Again, I think it makes more sense. All right, so this next portion I think is relevant to all of you as nurses, because you'll may be on a call with a patient who's asking follow up after, a visit with me or one of the other providers. Should I take this medication? I'm concerned about the risk. Or you get the call that someone's newly pregnant and they're like, should I stop my antidepressants or the medication I'm taking for anxiety? So it is important to be prepared to discuss our general principle that if you're on a medication that's working, in general, we will keep you on it. They may get more specific in their questions around some of the risks that they've heard about, and then just want to spend a minute talking through what some of those items may be. So again, I don't know if anyone is actually looking at the screen right now, but for the sake of those who may not be, there is just inherently risk of undertreatment or not treating at all pregnant patients who have depression or anxiety. And those risks include limiting engagement in their medical care and self-care, substance use, preterm birth, low birth weight, preeclampsia, postpartum depression, impaired infant attachment, disrupted relationship with one's partner, and even suicide. So again, there are risks to a patient with depression or anxiety who does not get treated or is undertreated. The risk of the vast majority of medications that are used to treat these conditions, which are the SSRIs or SNRIs, the selective neurotonin uptake inhibitors, are fairly minimal. The big ones that come to mind, and you will read about and should be aware about, is persistent pulmonary hypertension in the newborn, transient neonatal adaptation syndrome, preeclampsia, you all know, and spontaneous abortions. Those the risk are very low, but I think the one that folks may be a little less familiar with are the first two. And just this is a slide you can reference with the generic and trade names for the commonly used, medications for depression, anxiety. I'm not going to read through those. But let me just start with persistent pulmonary hypertension. Again, what is this? This is, normal. The normal physiology is after the baby is born, the pulmonary vascular resistance drops. But when that doesn't, there is shunting from the right side of the heart to the left, which means unoxygenated blood is shunting to the right, and the baby could become hypoxemic. The incidence is very low. It's about 2 to 4 in 1,000 um, births for women who are taking these medications. It's mostly associated with women who are taking SSRIs beyond 20 weeks, and it's not drug specific. It's mostly associated with the group of SSRIs. And it's usually associated with early neonatal distress, maybe some cyanosis, poor oxygen response, and it's generally diagnosed by fetal or neonatal echocardiogram. The treatment is NICU support, inhaled nitrous oxide, plus minus vasodilators, and ECMO very rarely. Survival is well above 90%, and most babies have very good long-term outcomes. So, point to make, very rare, happened very infrequently. Survival is excellent. There's treatment. And again, when looking at this compared to the risk of untreated depression or anxiety, I think the scales of risk benefit weigh in the direction of taking medication. The other thing is transient neonatal adaptation syndrome. You hear people refer to like the baby withdrawing after birth. This is generally a self-limited constellation of symptoms, neurologic, respiratory, and GI. And again, this is related to in utero SSRI exposure. It is much more frequent than transient tachypnea of the newborn because it does occur in about a third, almost a third of babies who were exposed to SSRIs in utero. But it is transient only, lasting only a few days to a couple of weeks, and there's no long-term sequelae or adverse outcomes associated for the baby. It can be associated with jitteriness, tremor, irritability, hypertonia, difficulty feeding, mild respiratory distress, and it's usually, the onset is fairly quickly after the baby is born. And the treatment is supportive care. But again, it's common, but it's transient, non-life threatening. And again, looking at the scales of risk benefits for treating depression, anxiety, and the risk associated with not treating, again, I think the scales are weighed in the direction of leaning towards treating the mom. One thing that does come up is sometimes you'll hear, moms need to have a fetal echocardiogram if they're on an SSRI. And this was, based on some small studies, not well designed. And initially, ACOG was recommending consideration of a fetal echocardiogram. ACOG and now SMFM, Society for Maternal Fetal Medicine, are both very clear. You do not need to get a fetal echocardiogram just because a patient is on an SSRI. As I mentioned earlier, it's different if someone is taking lithium for their bipolar disorder. Those patients would need a fetal echocardiogram, but someone who is just simply on an SSRI would not. And then another question that comes up is Paxil. Everyone thinks of, the SSRI in pregnancy as Zoloft. But occasionally we have patients who are on Paxil, or a patient who has taken Paxil in the past and has responded well. And I think sometimes there's a thought that, we shouldn't, have our pregnant patients take that. And the reason is because there were some studies suggesting a small increased risk for congenital heart disease. Um, and so the current ACOG and SMFM recommendations is that if you are starting someone on an SSRI, there are better choices. So don't start someone on Paxil, but you should start them on, as we discussed, Zoloft and Lexapro. If someone was already taking Paxil and they were doing well on it, then they can stay on it. Um, and so, because there are risks to switching SSRIs, or even taking somebody off, as we discussed. So if someone's naive to an SSRI and you need to start them, don't start them on Paxil. But if they've taken it in the past and it's worked well, please continue them on it or counsel them that it is okay to continue Paxil. All right. Um, Jumping into treatment, and I know I am going fairly quickly, so I hope everyone is still following me. So general treatment principles is, sorry, that's my Alexa who's just speaking on her own at the moment. Uh, General treatment principles, common mental health disorders are within the scope of obstetric practice. So we should all be comfortable screening, identifying, treating pregnant patients with mental health disorders. Um, we should be using the lowest effective dose for treatment. And we should be avoiding polypharmacy. So if someone is on a medication, it is better to up titrate than to add a second agent. We should also, as was discussing with the Paxil issue, we should minimize switching medications. And most importantly, just to make sure that this point is clear, we should be considering untreated or inadequately treated mental health disorders as an exposure for adverse maternal and fetal and newborn outcomes. Um, It's important to note, just as you all know, the volume of blood expands during pregnancy in preparation for delivery. So it is highly conceivable that we will need to up titrate medication during pregnancy because of the physiologic changes. We should not down titrate medications in the third trimester to avoid neonatal withdrawal symptoms. And pregnant patients who are diagnosed with anxiety or depression during pregnancy or postpartum should continue treatment for at least 6 to 12 months of symptom remission before considering discontinuation. And this is important because many patients will ask, when should I stop? When should I get off? And we all know that there is risk to stopping too soon, that patients will relapse, will deteriorate, and ultimately need to be back on medication. And then, of course, we should never abruptly discontinue SSRIs or SNRIs because they can be associated with symptoms including GI upset, dizziness, fatigue, tremors, headaches, and even patients will describe electric-like shocks. Um, I'm not going to read these next few slides in tremendous detail, but they are very helpful to reference. At some point, they may be good to print out because I think it provides very good guidance on what the starting dose should be for all SSRIs and how and when to titrate up. And the only thing that I would say that I think is important is that um, we should be assessing response to treatment with the tools that we have. So if we screen someone with a PHQ-9 and we identified that, they had, depression and we started them on therapy, we should be rescreening them with a PHQ-9 to determine their response. And if they are not responding, then we should be titrating up. And this goes over sort of the timing of how and when to do that. Again, this is largely going to be done by physicians, but I think for awareness, it's helpful to know what these starting doses are, what the maximum dose is, and how we titrate. And that is a next of the several slides. So one thing I do want to mention, you may recall that the FDA, it's been a couple of years, approved an IV medication. It was in the news. It was the one where you were going to have to be hospitalized and receive an infusion over several hours for the treatment of postpartum depression. That is subsequently no longer FDA approved and has been removed from the market. So that is no longer an option for our patients. Just a word around lactation. Um, so we do not recommend stopping psychiatric medications just due to lactation alone. Um, the important point is that if you were taking it during pregnancy, that exposure in utero for the fetus exceeds any exposure that the baby would receive in breast milk. So that was sort of the second thing I just wanted to make sure that everyone remembers because inevitably you're going to be asked about this by a patient. You know, is this safe to take while I'm breastfeeding? Should I discontinue? Should I wean my antidepressant or my anxiolytic? And the answer in general is no, because of the risk of relapsing or deteriorating. And quite honestly, the risk of exposure was greater while the baby was in utero than it is through breast milk. If we do need to initiate treatment in the postpartum period, again, the principles are generally the same. Start with an SSRI. Zoloft is preferred. Lexapro is the second choice. If someone was on one that worked for them in the past, we can consider it. Um, Fluoxetine, so Prozac, does have a longer half-life and does have higher infant exposure, but it can be used. Um, and again, we want to avoid polypharmacy. We want to avoid using multiple medications while someone is lactating, and we do want to avoid the use of benzodiazepines because it can be sedating and can cause feeding issues um, um, if they are using it. All right, so just a couple of things about team-based care. Everyone plays a role, our medical assistants, you as our nurse, our advanced practice providers, our PAs, our nurse practitioners, our physicians. We all are involved potentially in the screening, identification, the management, the follow-up of our patients. Our medical assistants are often our first line for administering our validated screening tools, whether it's EPDS or PHQ-9. I think they are really important in normalizing mental health screening as routine care for all our patients, including our gynecologic ones. Um, they are also important for escalating any positive suicidality to either you, the nurse, or to us as the providers. And they are also important for coordinating follow-up and referrals before um, patient checkout. I'm going to go on mute for 1 second and um, turn my video off for just 10 seconds. I'll be right back. Sorry about that. And so for our nurses, you'll also be critical in reviewing screens, getting the phone calls, reviewing medications, getting medication questions, and I think are critically important in reinforcing the importance of potentially treatment, the importance of therapy, getting patients to therapy, which can always be the first line for mild to moderate depression or anxiety. Not everything has to be treated with medication, but when it is needed, reinforcing that untreated depression or anxiety carries not insignificant risk and potentially more risk than the actual medication itself. You are also important in in phone triage, if someone is calling, you may be the first one who recognizes that someone is not doing well, whether they're tearful or agitated or have very pressured speech or sound delusional. Those are things that you will be critical in sort of first line management, identifying those patients, perhaps using one of our screening tools, and also escalating either to a physician, an APP, or one of our social workers, or getting a patient connected to a therapist. Um, and the important thing, as a system, as an office, as a provider, as someone giving this talk, is that it is important that we connect the dots between, screening and other interventions. It's great to screen, but if you don't have the system in place, to provide follow-up and the necessary treatment, the screening becomes pointless. And I think for the most part, we do a great job at that. As I mentioned, I think we do have a little bit of an opportunity with perhaps screening patients who screen positive for depression, for bipolar disorder, to make sure that we don't, accidentally or inadvertently uh, create worsening mania or psychosis in a patient who's actually has bipolar, and we treat them with an antidepressant. All right, so we do have, policies in place for in ambulatory around the clinical management of patients, particularly with active suicidality. I'm not going to read this slide, but I am going to go over the next one in terms of what to do because some of us work in the DCAM, some of us work out at the network sites and don't have access to an emergency room. But if there is, see if it's the next slide, sorry, I'm going backwards. Just a key principle to reinforce that's in our policy is that safety overrides convenience. If someone has active suicidality, it requires continued observation and a emergency room transfer, whether you're offsite or on campus. And for those who, can see the algorithm that is up, if someone, actually, let me go back for a second. If someone does screen positive for suicidality, you suspect someone is suicidal, they express that they are. The first thing to do is get help, notify someone, whether that's a clinician in the office, an APP, or a physician. And then whether that's the physician or you, determine active suicidality. Do they have an intent, plan, any recent behavior? Um, and if they do, if they are at active risk of suicide, we do need to make sure that someone is observing them. And sometimes that will be a nurse, sometimes we engage public safety, but it generally involves someone keeping eyes on the patient, continued observation within 6 feet, an unobstructed view, making sure that ligatures are removed from the room, anything else that could potentially harm the patient, and just again reinforcing the patient can't be left alone. Getting social work for those sites who may have social work on site or behavioral health, engaging public safety to prevent elopement, and then ultimately arranging direct transfer to an ED. If these are places like Hyde Park, Crown Point, this becomes easier. If you're at a network site, it does mean calling 911 to get the patient to an emergency room. Rarely, but occasionally, we do need to consider involuntary petition if there's imminent risk or lack of capacity. Again, that will require a clinician to help with that assessment. In the policy itself, there is a link to the forms that need to be completed for involuntary petition. And then all of this obviously needs to be documented in Epic. And if a petition was completed, it ultimately will need to be scanned into the EHR. into Epic. Um, if you're on the phone with the patient or on video for whatever reason, for the most part, the algorithm follows the same. Obviously, keep the patient on the phone or video. Don't allow them to hang up or disconnect. Confirm their location. And obviously, while you're doing that, call for backup so that you can get some help. Engage a second staff member if you can. I assume this will be a little bit trickier if one of you are working from home. That may involve calling someone to say, I have an active suicidal patient on the phone or on video. Try to calm or de-escalate. And then we do need to call 911 and get someone to that location for a wellness check. Stay with the patient until 911, until EMS arrives. And then once they do, they will take over, and then ultimately psychiatry. So this algorithm is part of that protocol. And if you have not seen it or not familiarized yourself with it, I do think it's valuable. Again, we're not going to have to do this often, which makes it more challenging to remember these steps. But when it does happen, you do want to be prepared and know what you should do. There are tons of resources on our internet for a variety of disorders. They are displayed on the slide. They actually all do link to the various tools. So everything from, for anxiety disorders, adult anxiety screening and management, how to, panic screening and management, insomnia screening and management. There's literally about 20 things listed. The clinical decision support tools for suicide, PTSD, domestic violence, alcohol use, tobacco cessation, opioid use disorder. There are various things for our pediatric and adolescent population. So again, there is a plethora of resources on our internet that are available to you. Okay. One thing that I want to make sure that you're aware of, it's something I use all the time. And I imagine you all get asked not infrequently, is this medication safe to take in pregnancy? And while you may not want to be the one to make final recommendations whether um, someone should take a medication, those are often sent to the physician to help decide. There are some resources that can help you to determine, should someone stop something immediately? Is this really teratogenic or harmful or advised not to take during pregnancy or while breastfeeding? And I always use micromedics. The problem is finding micromedics because it's not easy to find. But my slide deck will go over it. Obviously, this recording will go over it. But you will essentially want to go to clinical resources. Under clinical resources, you want to find under drug information, micromedics. You'll select micromedics. And then there will be a screen where you can enter the drug. I put in valproate because we know it's teratogenic, not something you should take in pregnancy. And then you will want to look under reproductive risk. And the really nice thing is that it gives a very sort of detailed summary of what's known about the particular drug in pregnancy and lactation. It's always where I go to take a first look on drug safety. And I think it's very valuable in informing our patients about safety in pregnancy and lactation. Couple of things have been asked that have also come up. We do send pre-visit questionnaires out to patients, and there's some discomfort around, they're sent out a couple of weeks beforehand. Who's looking at them? And is there any risk to us as providers or to the organization for a questionnaire that's been sent out and perhaps hasn't been looked at or acted upon until the day of the visit? And the answer is yes. We have now ensured that there are disclaimers when those questionnaires are sent out to say, listen, these aren't going to be reviewed. They're going to be reviewed at the time of your appointment. If you do not intend to come to your visit, your care team will not see your responses. And then, of course, if you're having a medical emergency, feeling unsafe or immediate distress, please don't wait, call 911. And so just want to make sure that you were all aware that we do send a disclaimer when the questionnaires are sent out ahead of the visit, clearly stating that these will not be reviewed until the actual day of the visit. And then if you do not show, it is quite possible that nobody will see these responses. So I'm nearing the end, and I just want to point out a couple of high-level takeaways that I hope you will take away from this conversation tonight. So the first thing is we need to screen. We need to use validated tools, PHQ-9, EPDS in pregnancy and postpartum. As I mentioned earlier, we are going to be switching to PHQ-9, but we need to be using validated screening tools to assess a patient that you suspect may be suffering from depression or anxiety. We need through those screening tools, we need an objective way of screening the severity of those symptoms. And then again, hopefully I've emphasized this over and over, and that you will remember this. We need to screen for bipolar disorder if someone screens positive for depression because of the risk of inciting psychosis or mania with antidepressants in someone that we missed. So a really important point. And again, I think that's an opportunity for us to all do better on screening for bipolar disorder. Treatment, psychotherapy should be the first line for mild to moderate depression and anxiety. But if someone needs drug therapy for moderate to severe illness, we should not be afraid of treating them. It should be, of course, be shared decision making, but we need to counsel them correctly and appropriately about the risk benefits of both untreated or undertreated mental health versus the risk of those medications. And as we discussed, the risk of untreated or undertreated mental health outweighs those risks. And again, just to emphasize, untreated illness is an exposure itself. And then, of course, we need to monitor. So if we go down the path of treatment, whether that's therapy or whether that's drug therapy, we need to track their response with a validated tool. So if we did that with the PHQ-9, then we continue with the PHQ-9 and we evaluate their response. We should up titrate to remission, and we quite possibly may need to do that because of the volume of distribution in a pregnant patient increases. So particularly if they were on something at the start of the pregnancy, we are likely going to need to go up. But again, we need to be monitoring, assessing their response objectively, and making decisions about up titration. And then, of course, as I mentioned, a very important point, we should not be reducing dose. We should not reduce dosage of medications in the third trimester as a precaution to reduce the risk of neonatal adaptation or withdrawal syndrome. We should keep the dose the same. And then finally, if someone has bipolar disorder or suspected bipolar disorder, if someone has psychosis, suicidal ideation, or there are safety concerns, or if someone has severe disease, whether that's, depression, anxiety, OCD, and we can't seem to get it under control, we need to refer to psychiatry. That is everything that I had. We have about 10 minutes left. I think I saw some things come. Oh, no, nothing in the chat, but in the final 10 minutes, I'm happy to answer any questions or cover anything that hasn't been covered.
Dr. Nunes, thank you so much for doing this talk. I find that women in pregnancy, it's a window of opportunity, even more so than when they're postpartum. And it's a important time frame that many women feel like, oh, well, I want to be the best I can for my child that's going to be here soon. And so although they may be scared of using an antidepressant, especially if their quality of life is impaired or they're having, an inability to function the way that they want to, even in pregnancy. And most people know if they've had a past of things as well, maybe a time frame where we can get them on treatment and psychotherapy, if that's needed too. And our MAs and nurses often are that first line defense for us that often patients look to as trusted individuals for their opinion as well. So,
I mean, the statistics are scary. As we started out with, 1 in 5 women will develop some mental health issue during a pregnancy or postpartum. I mean, 1 in 5 patients. And so we need to be very well equipped at um, educating our patients around the risk of no treatment or under treatment versus the risk of drug therapy. Of course, I'm a huge advocate of therapy. In my 30 years of doing this, it is challenging to get patients to commit to therapy, although it has become much easier with virtual care. Um, but we need to be armed with the information to make sure that we are providing our patients with the best information so that when they are doing shared decision making, they are making the best possible one. And I guess the one thing I didn't probably call out enough, I think we all recognize that the most vulnerable time for one's mental health is the immediate postpartum period for all the very understandable reasons. It's the hormonal changes that occur immediately postpartum, combined with the lack of sleep and stress of a newborn, can really precipitate and exacerbate underlying depression and anxiety. And it's important to counsel our patients that is a risk. You may be feel like you're doing okay now, and your tendency may be to want to stop your SSRI, but there's a risk of your condition worsening while you're pregnant, but then an even worse chance of that happening when you have a newborn at home.
we'll get that algorithm for the suicidal response too. I think get it laminated and we can have them post it throughout our work areas and clinic too. Um, Also, I think with the clinical resources that you listed too, we can maybe even put those on the back. That was really helpful, even for people that aren't pregnant. So,
Yes, absolutely.
because we won't think about it as often, but when you need it quickly.
Yeah, I think particularly for the what do you do if you're on the phone or a video with a patient who's suicidal?
Yes. All right. Does anybody have any questions for Dr. Nunes? Here's your opportunity. All right. Looks like you did a thorough job. No one had questions. Thanks, everyone.
All right, thank you. Have a great evening.